Our speaker this week, who is a relatively new member of the faculty, Dr. Randy Auerbach. So Randy comes to us courtesy of the efforts of Maura Rinn and Jeremy Veenstra Vanderweel as a relatively new recruit from Harvard to join the child division. But he began his educational career at Cornell, received a bachelor's degree, and then his doctorate in clinical psychology at McGill, and then proceeded to do an internship at Harvard and McLean Hospital, where he joined the faculty and remained thereon at the level of assistant professor until he was recruited to Columbia in 2018, where he is now an associate professor. Randy's work has really been, not just prolific and informative, but in a particularly timely area, which has to do with youth mental health and specifically suicide, mood disorders, and self-injurious behavior. And in doing so, he's focused on utilizing multidisciplinary approaches to assessing the pathophysiology and potentially markers of vulnerability to suicide and self-injurious behavior and mood regulation, including electrophysiologic measures, MRI measures, and phenomenologic assessments. His work's been funded by a variety of sponsoring institutions, including the NIMH and a number of different foundations. And he's really a good addition, which I think occurs at a time when the idea of youth mental health, and specifically with a student focus, has become not just timely but acute, as we hear about both internally and in the media in terms of events occurring. And although his particular focus has been on suicide and self-injurious behavior, I would be interested either in the presentation or in the discussion if it could be extrapolated to violence as well. So without further ado, please join me in welcoming Dr. Randy Auerbach.
Good morning, and thank you for having me here today, and thank you for so many of you in the audience who have really helped provide a warm welcome as I transition here. And I'm excited to share some of the ongoing work in my lab on depression and suicide in adolescents. Depression in adolescents has somewhat of a pernicious course. Recent epidemiological data suggests that the lifetime prevalence is about 11%, and it represents this critical developmental window for us to begin to identify etiological mechanisms that confer increased risk during this time period. It's also a period where sex differences begin to emerge. Around the age of 14, females begin to experience twice as many depressive episodes relative to males, and this is actually a difference that persists well into adulthood. Between the middle and late adolescence, there's a 5-fold increase in the prevalence of depression. Again, thank you so much. Again, underscoring that we need to know more about what's going on during this critical developmental period. Despite the fact that we have a variety of different psychotherapeutic and pharmacologic approaches to treating adolescent depression, the average length of a depressive episode in adolescence is about 6 months in duration, and 40 to 70% of these youth will experience a recurrent episode within just 5 years of their initial diagnosis. Depression in adolescence has a number of negative impacts across key life domains. From an interpersonal perspective, they're reporting greater discord with parents, teachers, classmates, and peers. They're youth that are doing more poorly in the classroom, often being left behind. Research from my lab has shown that they're engaging in a greater frequency and a wider range of risk-taking behaviors. These are things like substance use, precocious sexual behaviors, and it's associated with both physical and mental health comorbidities. And these problems are directly related to the issues that these individuals face in adulthood, and perhaps most notably, 75% of adult suicide attempters report a history of depression that stems from adolescence. Despite the fact that depression is a leading cause of disability worldwide, research investigating early identification and treatment has been hampered by the heterogeneity of this debilitating disorder. In fact, there are 945 different ways an individual can uniquely present with depression simply based on the constellation of symptoms alone. And thus, my lab has initiated a line of research that has begun to systematically investigate promising phenotypes and biological markers that may help us to better characterize the disorder. In part one of today's presentation, I'll discuss recent findings from my lab unpacking the role of cognitive vulnerability more generally and information processing biases more specifically. Information processing is somewhat of a broad construct, and my lab has tended to focus on self-referential and emotion processing biases. These are core cognitive affective processes that have been implicated in both the onset and the recurrence of depression in adolescents. In addition to testing intermediary phenotypes through novel experimental paradigms, we've also used EEG, which provides excellent temporal resolution in the millisecond range, to probe cognitive affective processes that are hypothesized to be outside of one's conscious awareness, but yet key and core to driving some of the self-referential and emotion processing biases that we detect. Additionally, I've used low-resolution electromagnetic tomography, or LORETA, to probe cortical differences between healthy and depressed adolescents, particularly with a focus on exploring deficits and dysfunction within the prefrontal cortex. In part two of today's presentation, I'll discuss reward processing deficits in adolescent depression. This work is supported through animal studies that have demonstrated that dysfunction in mesocortical limbic pathways, which contributes to depressive-like behaviors in animals. Among humans, anhedonia, or this reduced ability to experience pleasure, has emerged as a promising phenotype in adolescents and adults. Converging evidence from neuroimaging studies characterizing the neuropathology of these reward deficits in depression has also highlighted dysfunction within mesocortical limbic regions in humans. And thus, for the past 2.5 to 3 years, we've been collecting data in low and high-risk healthy adolescents, high risk by virtue of a parental history of depression, as these individuals are 2 to 3 times more likely to develop depression themselves. At baseline, we collect a suite of neuroimaging data, including structural, functional, and resting data, and then we follow these individuals every 3 months for 2 years. And today I'll be presenting some preliminary cross-sectional and prospective findings with a particular focus on striatal regions. Presently, suicide is the second leading cause of death among adolescents ages 13 to 18 years. Although depression has a robust association with suicide ideation and suicide planning, it in fact shows a weaker relationship with suicide attempts. And thus, my lab has begun to probe cognitive and reward-related phenotypes and neurophysiological processes that may help explain why certain depressed youth engage in suicidal behaviors. And finally, in part 4 of today's presentation, I'm going to be presenting some preliminary findings from a recently completed CBT trial in depression in adolescents. At its core, CBT provides 2 primary targets: challenging cognitive biases and behavioral activation. These targets have provided the necessary etiological framework for us to explore promising phenotypes and biological markers, but it's also provided a nice framework for us to leverage important precision medicine initiatives. That being, can we begin to identify cognitive and reward-related neurophysiological markers that allow us to predict treatment response? And on the other side of the spectrum, can we begin to detect what actually is changing, normalizing, or improving in the context of therapy? As a whole, we believe this comprehensive, multimodal approach from etiology to treatment has contributed to an improved understanding of depression in adolescents. In part 1 of today's presentation, I'm going to be focusing primarily on self-referential processing biases, and for these studies, I make use of EEG again, just given the excellent temporal resolution afforded. Beck's cognitive theory of depression suggests that depressed individuals have a tendency to focus and perseverate on negative stimuli within their environment, and this perseveration and focus on negative stimuli and attributing negative stimuli in one's environment as being self-relevant contributes to a negative self-view as well as an increase in one's depressive symptoms over time. Depressogenic self-referential processing is associated with 2 core cognitive vulnerability factors, the first being maladaptive schemas, which are stored representations of the self that are forged through early life experiences. And these schemas are thought to be activated automatically in the presence of stress and thought to play a driving force in contributing to depression. On the other side of the spectrum is rumination, which is a slower going process. Rumination is this tendency to perseverate on one's depressive symptoms, and now decades of research on response style theory has shown that a ruminative response style also increases the severity and duration of one's depressive symptoms over time. Although the occurrence of these more automatic and elaborative processes have been largely accepted amongst clinicians and researchers, Few experimental paradigms provide the requisite temporal resolution needed to capture these more automatic and elaborative processes, and thus we developed a modified self-referential encoding task to begin to probe event-related potentials that may be associated with some of these processes. When we had healthy and depressed adolescents come into the lab and complete the self-referential encoding task, while EEG data were collected. On a given trial, they saw a fixation cross followed by a positive or negative adjective, and these words were drawn from the new dictionary and matched on relevant characteristics. The words were presented very quickly, just 200 milliseconds, and then there was a fixation cross delay that was presented for 1,800 milliseconds, and this is where we really wanted to begin to explore some of our ERPs of interest. After the fixation cross, there was an explicit prompt, does this word describe you, yes or no? In particular, we were interested in probing the P1 and the late positive potential. The P1 occurs approximately 100 to 200 milliseconds post-stimulus, or about 100 seconds after the presentation of the word, and it's believed to reflect the semantic monitoring of emotional information, which we believe maps onto this automatic elicitation of schematic content. Additionally, we looked at the late positive potential, which initially starts to emerge around 300 to 400 milliseconds after the word is presented and actually can persist over the course of seconds, which is really dictated about how long you present the stimuli. Initially, the LPP is maximal and parieto-occipital regions of the scalp, but then propagates forward to frontocentral regions later in the time course. Before I begin to unpack some of the findings, I just want to make one note. On all of the data slides I'm going to be presenting today, I present the statistics at the bottom of the slide just for the sake of transparency, but I'm also going to walk you through exactly what we find in each one of our slides. So I'm going to first walk you through some of the behavioral data. So in panel A, we have words endorsed on the y-axis, positive and negative words on the x-axis. The healthy group is in gray, and the depressed group is in red. And what you're seeing is a group by condition interaction such that the depressed group endorse fewer positive words as being self-relevant and more negative words as being self-relevant. We also look at reaction time in panel B, and this is how quickly they're endorsing positive or negative words as being self-relevant. And again, a group by condition interaction emerges here such that the depressed individuals are slower at endorsing positive words as being self-relevant and faster at endorsing negative words as being self-relevant. There's also a distractor followed by a surprise recall task, and again, a group by condition interaction emerges such that for the depressed group, they were calling fewer positive words that were self-relevant and more negative words as self-relevant. This provides a good touchstone in order to begin to explore some of our neurophysiological components of interest. And just to orient you to these slides, if I could draw your attention to panel A, we have amplitude on the y-axis with positive going up. We have time in milliseconds on the x-axis. 0 is when those words are presented, and just to remind you, they're only presented for 200 milliseconds. We have negative words in red and positive words in black, and the healthy group is in panel A. I'm going to be looking at components in the parietal regions of the scalp, focusing first on the P1, which again is occurring 100 to 200 milliseconds post-stimulus. What we're seeing here is a group by condition interaction, which is largely driven by the fact that for the healthy group, we're seeing these enhanced amplitudes for positive relative to negative adjectives, which is largely absent in the depressed group. When looking at the LPP, which again reflects this elaborative encoding of emotional information, we're seeing again a group by condition interaction here, such that for the healthy group, we're seeing these sustained positivity for positive versus negative adjectives, but for the depressed group, you see this exact opposite effect, that they're showing these enhanced amplitudes for negative relative to positive adjectives. We also look at the LPP in frontocentral regions of the scalp where it becomes maximal later in the time course. Here we're looking at it from 600 to 1200 milliseconds. And again, a group by condition interaction emerges here such that for the healthy group, you're seeing these sustained and enhanced amplitudes for positive versus negative adjectives. And again, in the depressed group, you see this exact opposite effect, particularly later in the time course where there's greater amplitudes for negative versus positive self-relevant adjectives. Yes? Yes, and so within and between groups were significantly different. So we were also interested then trying to determine from a cortical perspective where some of these differences may have derived from. And so we used Loretta to begin to look at differences between healthy and depressed individuals following negative stimuli. What we found was that across the P1 and the early LPP, that there was this relatively reduced activity in the inferior frontal gyrus and medial temporal gyrus in depressed relative to healthy individuals, which is consistent with research probing cognitive control in depressed adolescents. And it certainly raises the possibility that depressed adolescents are under-recruiting frontal limbic circuitry that's typically used to modulate arousal to negative stimuli. We're also seeing somewhat of an interesting finding in that depressed individuals are showing greater relative activity and current source density in the precentral gyrus. And this is of interest because there has been a recent study of behavioral activation in adults which has shown that greater activity within the precentral gyrus in the context of a behavioral activation trial actually predicted out treatment response. And all of the depressed adolescents in the context of this study were undergoing 12 weeks of individual CBT, and so it provides potentially a target in order to test whether this is more of a generic area of treatment response or maybe specific to certain types of interventions. Well, we've found those findings to be promising, but there's a confound in the sense that we really couldn't determine whether the effects that we were seeing were a cause or a consequence of depression, given that they were currently depressed. And so I had a unique opportunity to embed this task into an ongoing study of high-risk youth that was ongoing at Stony Brook, where a colleague of mine was until very recently. He subsequently has moved to Florida State. Within this study, they were recruiting children and adolescents ages 8 to 14 years old, and these, again, were low and high-risk individuals, high-risk by virtue of a parental history of depression. In the depression field, we're kind of one-trick ponies for our high-risk samples. You'll see a lot of studies where we're recruiting by virtue of a parental history of depression. And these individuals were otherwise healthy, no history of psychopathology. And what we see, again, is similar to what we saw in our currently depressed sample was a group-by-condition interaction. Here I'm showing, again, amplitude on the y-axis, but focusing primarily on the LPP. We have our low-risk group in the hashed line, our high-risk group in the full line. The group-by-condition interaction was significant. What you see when looking at the low-risk group amplitudes for positive and negative adjectives is that there's no differentiation in terms of the LPP. But what's so interesting is that when looking at the high-risk group, you're seeing that there's this enhanced LPP to negative versus positive adjectives, suggesting that the effect that we were detecting in currently depressed individuals may actually be present prior to the onset of depression. Just to summarize this section of findings, when we're looking at our currently depressed individuals, what we're seeing from a behavioral perspective is that these depressed individuals endorse more negative self-relevant adjectives, are faster at endorsing more negative self-relevant adjectives, and tend to recall more negative self-relevant adjectives after a brief distractor. We're seeing evidence of both early and late ERP effects, which may map on to the automatic elicitation of schematic content and this kind of more ruminative process in which they're encoding either positive or negative stimuli. What's most promising about these findings, I think, is really the second study, in which we're able to actually replicate our LPP findings in an otherwise healthy sample, but showing that these at-risk youth are showing this potentiated LPP to negative self-relevant adjectives. And not to give away the plot line of this particular study, but we've been following these individuals for 2 years, and what we're seeing in terms of our preliminary analyses is that the LPP to negative adjectives is prospectively predicting out depression symptom severity 2 years later, and we're still trying to determine if we could actually predict depression onset, which suggests that this might be a promising biological marker of depression. Additionally, we've also been conducting parallel studies using MRI. We wanted to grow off what we're learning with respect to our Loretta findings to better characterize the neural circuitry that may be implicated in self-referential processing, and specifically looking using fMRI to probe the default mode network, and in data that I'll present a little bit later in today's presentation, trying to be a little innovative in terms of how we might be able to utilize electrophysiology data in terms of integrating it with ongoing treatment trials. In part two of today's presentation, I'm going to switch gears in terms of both the topic and modality and focus primarily on our area of study with looking at reward processing and depression. And for these studies, I make use of both structural and functional MRI. With regards to our research in reward processing depression, a lot of this work has been guided by the research domain criteria. And the RDoC, as many of you in the audience know, provides dimensions of behavior that strongly map onto the neurobiology of mental illness. And within our area of study in depression, we've primarily focused on both the positive and negative valence systems, just given seminal animal work that's been done in this area. Animal studies have consistently shown that chronic stress occurring early in development leads to long-term dysfunction in the mesolimbic dopaminergic pathways and contributes to a range of depressive-like behaviors in animals, including reduced motivation to pursue reward, reduced social motivation, as well as blunted acquisition and expression of Pavlovian appetitive conditioning. With respect to adolescence, Davy and colleagues have shown and suggest that adolescence is also this period of heightened reward pursuit. And this pursuit of reward, particularly complex rewards like peer status and romantic relationships, and failure to obtain these more complex goals in certain situations may confer increased vulnerability to depression. B.J. Casey has an elegant line of work which has also shown that it's this period of asynchronous neural development. And more specifically, adolescents are learning and engaging reward with fairly developed equipment, this being the mesolimbic system. But the tools to modulate that reward, that being the prefrontal cortex, are by comparison fairly underdeveloped. And that mismatch or asynchrony may in certain cases again confer increased vulnerability to depression. It's not to say that reward pursuit is maladaptive. It's actually a normative process. But deviations from that reward drive, particularly blunted reward responsiveness, may provide enormous insight into our understanding of vulnerability to depression. Perhaps one of the earliest in the field to begin to explore and tackle this question in adolescence was Erica Forbes, and she has a series of elegant papers where she's walked through a number of different behavioral and neural findings. And in her earliest work, she showed that depressed adolescents had this inability to distinguish high versus low value rewards, and in subsequent neuroimaging studies was able to demonstrate that this inability to distinguish high versus low value rewards may stem from this blunted activation in the nucleus that come in both in response to anticipating outcome as well as receiving outcome. As a follow-up to the study, Carla Sharp completed a study in high-risk healthy adolescents and currently depressed adolescents. And in this study, she administered a fairly standard guessing task or gambling task in which adolescents were either won or lost on a given trial. And what she was able to demonstrate was, in response to outcomes, this low-risk healthy group showed this bilateral activation in what she's dubbed the ventral striatum, but what I would argue also bleeds into the dorsal striatum. And that pattern of activation following a win is largely absent in the high-risk group, again, high risk by virtue of a parental history of depression, as well as the currently depressed group, suggesting that this blunted activation within the striatum may be present prior to the onset of depression. While promising, there's been a failure in our field to actually replicate this effect in adolescents. Ahmad Hariri's group down in Duke has not been able to do it, and as a first pass before kind of pushing forward in this line of research, we wanted to see if we were able to replicate it before asking related questions. We recruited a group of low and high-risk healthy adolescents, all between the ages of 12 and 14, to minimize pubertal heterogeneity. Admittedly, we've actually recruited about 120 kids. These are all kids that are being scanned in Boston, but since the move, I've been unable to update these analyses, so I'm only presenting about a third of the data, but I don't think that these findings are actually going to change, and that's not for the positive, unfortunately. In our study, adolescents are completing what we call the guessing task, otherwise known as the door task. This is a task that has been developed by Greg Hychek. It's been used really extensively in the context of electrophysiology work. On a given trial, an adolescent is asked to choose a door. Had they selected this door, they would have seen a green arrow facing up, meaning they won 50 cents. Had they selected the other door, they would have seen a red arrow facing down, meaning they lost 25 cents. They're told at the onset of the trial that they have to break the pattern. And if they break the pattern, they can optimize their wins, and they're able to keep all of their earnings at the end of the trial. We did some quick and dirty Mars bars extraction using some of the parameters that other groups have used in their papers. And what the walk-away message is that irrespective whether you're looking at the low and high-risk group, we're seeing relatively identical patterns of activation for the low and high-risk group. So we're not able to actually replicate Carla Sharp's work. That said, we are following these individuals every 3 months to 2 years, and although this is a relatively small subsample of the data set, what we are seeing is that when you control for baseline levels of depression, that this relatively reduced activation for wins versus losses is prospectively predicting out depressive symptoms at the 3-month follow-up, and you're seeing a nearly identical effect in the left ventral striatum, but more specifically the accumbens. And so although we're not able to differentiate these low and high-risk individuals, it does give merit that this is a region of interest that should be explored more carefully. One area that our lab has been really interested in building, and it's an area that I think is fairly underdeveloped in the context of the RDoc matrix, this being the social processes domain. Our group has thought a lot about how best to explore social processes in adolescents, given that it's a period of time in their lives where there's increased autonomy from parents and greater reliance on peers. And this greater reliance on peers is leaving them open to greater opportunities for rejection and loss. And we believe that this might be a critical way to better disentangle depression during this time period. This is a task, this is called the chat room task that was originally developed by Amanda Geyer when she was working with Danny Pine at NIMH. And this task has been used in a number of groups around the country to explore primarily anxiety and small parts depression. And typically in this task, what they do is they take a fairly rudimentary approach to analyzing the data. And what they do is on day one of a given trial, participants come into the lab and they're made to believe that they're going to have this opportunity to engage same-age peers online and talk to them. And what they're shown is profiles of other teens participating in this nationwide study. They develop a profile of their own. These profiles are things that you'd see vis-a-vis Facebook, their likes, their interests, where they'd want to travel, what music they listen to, and things of that sort. And based on their profile and viewing other teens' profiles, they select out 30 teens that they would be interested or 30 teens they would not be interested in talking with online. Typically, research groups that have used this particular task have typically taken the interested group, the 30 or so subjects that they'd want to be interacting with, and then looked at, after they received feedback in the scanner of whether they were accepted or rejected by these teens, where was the pattern of activation most robust. But as all of you know, social processes are a bit more nuanced, and we don't necessarily always feel good when we're accepted by people that we like. We don't always feel bad when we're rejected by people we don't. And so we wanted to take a somewhat different approach and incorporate more of a prediction error way to model these particular data. So at baseline, they did in fact select out teens that they'd be interested or not interested. They were given this binary value, in this case 0 or 100. But when they came back a week or two later, before they went in the scanner, we actually gauge their expectation. And so here we're starting to build the rubrics of a prediction error model, because we know prior to them going in the model, we asked them, how interested do you think this particular teen and any other teen who's participating in the study would be in actually chatting with you? Next, when they go into the scanner, they're given the explicit feedback per trial by every teen participating in the study, and we rate how good they feel. And because we're able to extract their expectation value and their feedback rating, we're able to develop what we call a value encoding model, meaning we are able to obtain their subjective value, whether they're interested or not interested. We're able to look at the prediction error in terms of their feedback rating minus the expected values. And these actually are built in as regressors in terms of our whole brain analysis during the feedback period of data analysis. And when we do that, in contrast to other groups, it's really not a striatal pattern that emerges. And this is probably by no surprise. When you think about social processes in the context of your life, it's really this interplay between reward and DLPFC processes that are going to help navigate your way through social environments. And what we're seeing, just in a small sample of about 53 healthy individuals, we're seeing that really at the whole brain level, its medial prefrontal cortex arises. And what that activation actually means is that what we're thinking is it's kind of more social relationship salience. So it's not that greater activation is good or poorer activation is worse. It's just how important are social relationships to you? And when we see that, the MPFC is associated with greater perceived stress, and also by no surprise is we're seeing that areas of the amygdala are also becoming more active at the whole brain level, and this too is related to perceived stress. And so I think that the groups that have analyzed these data in prior studies have provided the necessary framework for us to start thinking outside the box to become a little bit more nuanced and textured. But I think moving forward for our lab, we're going to try to see if using this more nuanced approach may actually help us to differentiate these low and high risk individuals, and perhaps differences in the pattern of activation within these regions, whether that prospectively predicts out depressive symptoms. Our group also has been really interested in exploring neuroanatomical differences in depression, and particularly with a focus in terms of trying to identify transdiagnostic targets within depression. And a lot of this work has been guided by really powerful meta-analyses that have been done in my area. There are two meta-analyses in particular, one that was done by Kulshin and colleagues, and the other is done by Clemton and colleagues, that have found, by no surprise, evidence of broad-based neuroanatomical differences. But what they did find when comparing healthy and depressed individuals, and in the subsequent meta-analysis, healthy bipolar patients against depressed individuals, that when looking at the striatum, depressed individuals showed this relatively reduced volume in both the putamen and the caudate. And why that caught my attention is that this has been, by comparison, a lesser explored field. But there have been two published papers that have found that reduced volume within the caudate was associated with higher levels of anhedonia. In the first of the two papers, Harvey and colleagues looked at trait anhedonia in the context of 27 healthy individuals and showed that, again, reduced volume in the caudate was associated with higher levels of anhedonia. And Diego Pizzagali's subsequent study with currently depressed individuals also showed the same effect. What we were interested in doing as a group was determining whether, again, you could extend these findings to younger populations, but determining whether we could actually predict out anhedonia in otherwise healthy individuals. We completed a study where we looked at volume using an ROI-based approach. We focused on the caudate in green, the putamen in red, and the nucleus accumbens in blue. And we were looking at 50 healthy adolescents and then following them longitudinally over time. What we were looking at is not just whether we could predict anhedonia, but determining whether this effect was specific to predicting anhedonia while controlling for things like depression and anxiety, which may be more common. What we show here is we have anhedonia on the y-axis, and these are the residualized values as we're controlling for baseline levels of depression, anxiety, and anhedonia symptoms. And we see that reduced volume of the putamen is associated with higher levels of anhedonia symptoms at the 3-month follow-up. And you see the exact same effect in the right putamen, again, accounting for a fairly substantive portion of the anhedonia. We see that no other neuroanatomical region, that being the caudate or accumbens, was associated with anhedonia. And we see that none of these subcortical volumes are actually predicting out depression or anxiety symptoms. And so this seems to be a fairly stable effect. Just to summarize this particular section, so in contrast to Carla Sharp's work, we're not able to actually differentiate our low and high risk individuals just based on our monetary reward task. That said, I think that there is still merit in terms of predicting out vulnerability to depression with a focus on the striatum, as we're even seeing in a relatively small sample of about 40 adolescents that relatively reduced activation within the accumbens is prospectively predicting out depressive symptoms. And we're going to be able to actually arc the trajectory of those depressive symptoms as we're following them every 3 months for 2 years. One area that I think we're particularly excited about is trying to better capture social processes in the context of depression. And we're, for now, focusing on this more value-based modeling approach, which incorporates some rudimentary prediction error modeling, which we feel may better capturize what's going on in the context of adolescents' lives. We're also think that focusing on neuroanatomical differences is actually kind of enormously promising in many, many regards, particularly with a focus on identifying transdiagnostic mechanisms that may cut across disorders. Our data kind of point to this effect within the putamen, but as I mentioned, prior work has really shown the caudate. And one possibility for these differences in terms of adult versus the adolescent literature is that the putamen has been heavily implicated in a lot of motor processes. And perhaps during the initial manifestation of anhedonic symptoms, it could be that there's this motor shutting down as adolescents begin to isolate and remove themselves. And as they begin to isolate and remove themselves and become more fatigued and more lethargic, it could be that these more complex cognitive symptoms begin to emerge. But we think that in so much as we're able to identify this promising neuroanatomical target and we're following these individuals over time, one other possibility that differences morphologically may actually be related to the different trajectories of symptoms. Anhedonia is a symptom that's been implicated in depressive disorders, of course, but it also plays a prominent role in substance use disorders, thought disorders, and suicidal behaviors. And so it could be that differences in morphometry may actually be related to different long-term outcomes. But more broadly, our goal is to scan about 200 youth. And so we've scanned about 120 individuals, and I think our broad-based goal is really to not just predict depressive symptom severity over time, but actually predict disorder onset. And I think we'll have a unique opportunity in so much as we'll have about 100 females and 100 males that will be able to map potential sex-specific pathways that lead to depression. As noted earlier, rates of suicide continue to rise, and I believe that there's this critical need to identify different mechanisms that confer increased risk to suicidal behaviors. And my group has focused on really beginning to probe cognitive and reward-related phenotypes and neurophysiological processes, which may allow us to determine why certain depressed youth engage in suicidal behaviors. Make no mistake, we are amidst a public health crisis. Around the world, there's about 1 million suicide deaths each year, and within the United States alone, there are about 40,000 suicide deaths. With adolescents more specifically, it's the second leading cause of death, resulting in 2,000 suicide completions each year. And I said this earlier, but it certainly bears repeating that 70% of adult suicide attempters report a history of depression that stems from adolescence. Despite the enormity of the problem, the clinical correlates that delineate risk for suicide in adolescents remain painfully unclear. And this was really brought to the fore by a study that was done by one of my postdocs, Jeremy Stewart, in which he recruited psychiatric inpatients. These were adolescents that were admitted for acute psychiatric care because they either couldn't keep themselves safe, they were at risk to make a suicide attempt, or had recently made a suicide attempt prior to hospitalization. He recruited them within 48 hours of admission for the psychiatric care, and what he was able to demonstrate, so we have days in the past year on the y-axis, we have ideation and plans on the x-axis, our attempters are in gray, our non-attempters are in blue. We see no evidence of differences in the number of days that attempters and non-attempters ideated prior to admission, and we saw no difference in the number of days that they made a plan to end their life prior to the psychiatric admission. We also see in panel B there's no differences in depression severity, unless you think this is more moderate. 16 is thought to be a cutoff for moderate depression. We saw no differences in anxiety severity. We saw no differences in suicidal ideation severity. We saw no differences in sociodemographic differences. In short, these are an incredibly difficult group to parse apart. Thus, one of the critical frontiers in suicide research is to identify mechanisms that differentiate suicide ideators from suicide attempters. 1/3 of suicide ideators are going to go on to make a suicide attempt, but the mechanisms that facilitate the transition from thinking about suicide to attempting suicide are unclear, and thus I'm going to be presenting data today that has shown some promising ways by using different types of cognitive and reward-related tasks. One area of research that has received an enormous amount of attention, particularly with adults and adolescents, has been cognitive control. And there are really two competing theories in this camp. The first is the cognitive model of suicide, and this really maps on to those self-referential processing biases. And what the model suggests is that suicidal individuals tend to focus and selectively abstract out suicide-related stimuli within their environment. And this selective abstraction and perseveration of the suicide stimuli increases one's suicidal ideation and subsequent risk for suicide. The competing model is this neurocognitive model of suicide, and says it's really not about the selective abstraction of suicide-related stimuli. Rather, suicidal individuals tend to become overwhelmed by all emotional stimuli, and this kind of emotional cascade leads to a dysregulation and diminished cognitive control. The task that's typically been used to tease these effects apart has been a modified Stroop task, and within this task, an individual is presented with different color words, and these are suicide-related stimuli, positive, negative, and neutral-related stimuli, and the goal of the task is simply to identify the color of the word as quickly as you can. Within the task, when you're identifying the color of the word, if it takes somebody a longer time to actually select the color of the word, that means that there's this greater interference bias, or their cognitive control is more diminished. And research that has used this task have shown that in adults, in suicide attempters compared to psychiatric-controlled adults, that a suicide-specific interference bias, so just on the suicide-related stimuli, differentiates these groups. And in a subsequent study that was done by Christine Cha, she was able to demonstrate that a suicide-specific bias actually prospectively predicted out suicide attempts within 6 months. We wanted to test the downward extension of this model, just given that adolescents have profoundly different executive functioning machinery, but we also wanted to determine whether the suicide Stroop task was mapping onto suicide ideation more generally, or suicide attempts more specifically. And so we provided the first study that actually compared suicide ideators and attempters with comparable levels of mental disorders, symptom severity, and suicidal ideation. I cannot emphasize enough how much these two groups were remarkably similar. What we have here is interference scores on the y-axis. Again, a greater interference score connotes diminished cognitive control. We have the suicide, negative, and positive stimuli on the x-axis. Ideators are in red and attempters are in gray. And what you see is, and it's fairly obvious, that there's this main effect for the suicide attempters such that across all of the emotional stimuli, not specific to suicide stimuli, that there's this general deficit in terms of their ability to complete the task. We have a subset of the suicide attempters, which were also multiple attempters, and you see that this effect is even more strong when focusing specifically on the multiple attempters, again, suggesting that the model that we would support more with respect to our findings is actually the neurocognitive model of suicide. We're also interested in looking at reward-related deficits and potentially finding ways to integrate kind of reward-related deficits with the neurocognitive model of suicide. Dombrowski and colleagues' work suggests that suicide attempters have this inability to integrate rewarding experience, which he would argue stems from deficits within the paralimbic cortex. There's also support from a structural perspective, as Vang and colleagues have shown, that suicide attempters relative to ideators show an abnormal striatal structure, specifically reduced volume within the caudate nucleus. But even at a symptom level, there's actually some fairly strong data to suggest that anhedonia may play a driving force in suicidal behaviors. And so now in a study that is fairly dated, Fawcett and colleagues actually demonstrated that among psychiatric inpatients, higher levels of anhedonia assessed while an inpatient prospectively predicted out suicide completions within a year of hospital discharge. And a study that Matt did when he was a graduate student at Yale was able to demonstrate in children ages 6 to 13 that suicide attempters showed higher levels of anhedonia relative to ideators. We wanted to, again, test this in comparable ideators and attempters. Again, groups that don't differ in suicide ideation, symptom severity, and their composition of mental disorders. But interestingly, what they did differ in was, again, anhedonia, with attempters experiencing higher levels. And this provided us this unique opportunity to begin to understand how does anhedonia in the context of this population compromise their ability to integrate rewarding experiences. So we used a task that was originally developed by Jim Gold, whose focus of work is looking at trying to distinguish pathways for positive and negative symptoms in schizophrenia. We modified this task for adolescents, but on a given trial in this task, an adolescent is asked to essentially select an easy option or a difficult option. The easy option, one would obtain a $1 reward value, and to obtain that reward value, you merely need to press a key 10 times, inflate the balloon until it popped. For the difficult option, the reward values range from $3 to $7. To obtain that value, you have to press a key 50 times, inflate the balloon to a pop. The wrinkle in this task is that 50% of the trials, the outcomes are certain. And on the other 50% of the trials, the outcomes are uncertain. There's a 50-50 likelihood that you would receive the reward. But the goal of the task is to earn as much money as you can as the top 3 earners win a $50 Amazon gift card. So irrespective whether the outcomes were certain or uncertain, the participants should always be incentivized to select the difficult option. What we hypothesized was that these more anhedonic suicide attempters would be less likely to pursue the reward, and that's exactly what we found. So we have probability of selecting the difficult option on the y-axis. We have the difficult reward values on the x-axis. The ideators are in red, and the attempters are in gray. And you see this really nice main effect, such that the ideators are always more inclined to choose the high-value reward. What's so interesting about this effect is that it completely goes away when the outcomes are certain. What you may be saying to yourself was, well, that kind of would map onto effort, but it really wouldn't map onto reward integration, and you'd be absolutely correct. And so what we then did was did a series of trial-level analyses, such that we were interested in determining what happened when an individual received a reward on an uncertain trial. Did that increase the likelihood that they would pursue the reward on the subsequent uncertain trial? So again, we have the percent likelihood of selecting the difficult option on the y-axis, ideators and attempters on the x-axis, reward is in gray and non-reward is in blue. And what you see with the ideators is that 70% of the time that they received the reward on the uncertain trial, they were likely to pursue the difficult option in the subsequent uncertain trial. But for the suicide attempters, it was 50-50. It didn't seem that they were integrating the rewarding information to inform future decision-making. Whereas the ideators were exhibiting what we would call kind of a classic win-stay approach. the attempters, they really weren't able to anchor their decision-making to any of the information that they were receiving in the context of the task. We wanted to take it one step further. We wanted to try to determine from a neurophysiological perspective, can we begin to identify neurophysiological markers that may be contributing to their inability to distinguish signal from noise? So we used the task that I presented earlier today. This is the social reward task, in which adolescents are made to believe that they're going to be accepted or rejected by same-age peers, except this time we're using the context of an electrophysiology study, so they're either accepted or rejected. And just to show you kind of the level of buy-in, so after they receive the feedback, this on the y-axis we have how does this make you feel? These were trials in which they were interested in the peers. When they were accepted by peers that they were interested, you're showing that they're feeling better about themselves. When they were rejected by same-age peers, that they felt worse about themselves. We were interested in looking at the late positive potential. Again, this ERP component reflecting this kind of elaborative encoding of emotional information. We looked in, again, parietal occipital areas of the scalp. And what we see is a group-by-condition interaction emerge here. And what we're seeing among the ideators is that there are these enhanced positivity for being accepted relative to rejected. But what we see with our suicide attempters is that there's no differentiated these groups. But what I want to make most note of is that the amplitudes of both the accept and reject stimuli are comparable to the amplitude of being accept in the ideator group. And what I want to hearken this back to is that when looking at these kind of neurocognitive model effects using our cognitive control task, we're seeing that among our attempters, from a neurophysiological perspective, there's just this general over-arousal. There's no way for them to kind of modulate their neurophysiological response or their behavioral response in any of these tasks. And I think their inability to do so really compromises their capacity to separate signal from noise. So just to summarize, I think from our particular data, we're seeing both with respect to our neurophysiological and our behavioral phenotyping that there's more support for the neurocognitive model of suicide. Specifically, adolescent suicide attempts are just showing this general pattern of over-arousal, which is causing this, what I would believe, an emotional cascade, which is similar to work that has been done by Selby and colleagues, and shows that once this emotional cascade unfolds, it's really hard to kind of turn off the faucet, so to speak. We're also seeing, in large part, consistent findings with anhedonia. And we're seeing that not only are suicide attempters tend to be more anhedonic, but the presence of anhedonia is impairing their ability to integrate rewarding information. And we have preliminary data using our neurophysiological approaches suggesting that the inability to actually modulate may stem from this just general over-arousal, which we're, again, seeing in the context of our ERP data. One area that I really didn't have a time to get into today, but it's an area that our lab is kind of going full force in, is really trying to separate the what and the when. And so a lot of the processes that I discussed today really start to put a name to the what. So what are the mechanisms that are going to confer risk? But that what really doesn't answer the when, meaning when is an adolescent actually going to make a suicide attempt? And so our lab, and working with several other labs around the country, has begun to think more innovatively about how we could begin to detect these events in real time. And we have been given tentative approval for a grant that was just funded that we're going to be using passive sensing data. So focusing on using smartphone technology, so using the native technology that's being carried around in adolescents' pockets, purses, book bags, where we're going to be able to kind of look at what they're being exposed to, focusing on core suicide theory, things like interpersonal processes, emotional distress, and sleep patterns, and seeing how deviations in any of these patterns may actually confer risk in suicide. The reason that we think that this area of research is so promising is because we're always going to have the what-when problem, meaning we could do a really good job in the laboratory identifying mechanisms that confer risk, but that still puts us quite a chasm away from being able to intervene in real time. The advantage of trying to detect these suicidal states through passive sensing technology and adolescent smartphones is it allows us to potentially, if successful, and I admittedly know that that's a major if right now, but if we are successful, it allows us to start to think about how to deliver just-in-time interventions. So how do we reach adolescents in times of critical need when they're at most risk? And that may not be intervening with the adolescent. It might be intervening with the clinical team. It might be intervening with the parental units. And we could think creatively. But I think the study that was recently awarded provides us a first pass at trying to actually attack these suicide events in real time. Finally, in part 4 of today's presentation, I'm just going to briefly touch on some of our early CBT findings. And in particular, we weren't necessarily interested in kind of reinventing the wheel and testing whether CBT was effective. We know it's effective, but it's only effective in about 50% of all adolescent cases. What we're particularly interested in is whether we could begin to identify, whether we could predict treatment's response, to begin to think of how we could triage more effectively and only pushing teens into CBT when we know that they could actually respond. But on the other side of the coin, we're also interested in trying to see what's actually changing. So from a mechanistic perspective, what's normalizing or improving in the context of therapy? Again, I haven't had a lot of time to update some of these slides, so we've actually had about 35 completers in this particular trial, and all adolescents completing the study did a pre, mid, and post electrophysiology assessment. And what we see here is that there's a fairly standard attenuation of adolescent depressive symptoms from pre to post treatment. But what I want to focus on today is looking at whether certain neurophysiological processes normalized or improved in the context of the therapy. And for this, I'm focusing on that self-referential encoding task that I presented earlier in today's presentation. When looking at the P1, again, that's this component that occurs about 100 to 200 milliseconds post-stimulus, reflecting the automatic elicitation of schematic content. We're seeing that from pre to post-treatment, both for positive and negative words, that there's this general attenuation, but nothing that even remotely approaches significance. But interestingly, when looking at the LPP, again, this is the early LPP from 400 to 600 milliseconds post-stimulus, you're seeing, again, general attenuation. But what's so interesting to me, at least, on the surface, is that there is a particular attenuation for the LPP to negative words. And this makes sense to me in some regard. It makes sense that we're not really going to change schematic content in the context of 12 weeks of CBT, but it would be possible to change patterns of rumination. In the context of CBT, we're teaching people to attend to their negative automatic thoughts, we're teaching to challenge these automatic thoughts, and in certain cases, change these automatic thoughts. And perhaps what we're seeing in terms of this attenuation might be reflective of those processes. But in order to actually be confident about that, we also need to show that there's stability in our ERP effects in healthy individuals. And so this is a brief study that was done by a graduate student in my lab where we looked at healthy adolescents who completed a baseline ERP assessment and then a follow-up assessment 3 months later, kind of to parallel the time of the treatment. And what we have here are correlations on the y-axis, our P1, early LPP, and late positive potential effects on the x-axis. And what you're seeing is that there is remarkably robust, with 0.5 being a cutoff for a large effect size, remarkably strong test-retest reliability. And just for a measure of face validity, I wanted to put up our baseline and follow-up ERP components. Again, what you're seeing is that these are remarkably similar in terms of latency as well as the amplitudes, both at the baseline as well as the follow-up, which gives us a little bit more belief in our findings, specifically that the LPP to negative adjectives might actually be changing in the context of therapy. But we obviously still have a little bit way to go to analyze those data. So just to finalize this section, and this is one of my final slides, we still have a fair ways to go in terms of analyzing our CBT data, and we're interested both in kind of addressing both the normalization, but I think more pragmatically what we're particularly interested in is whether we could predict who is going to respond. And I think as a field, we've really stumbled over ourselves a little bit here because, more often than not, nothing is really doing better than self-report symptoms of depression. And I think if we're not doing better than self-report measures of depression symptoms, it really begs the question why we need to be doing some of this more intensive, labor-intensive and expensive assessments. I think that one of the promising avenues that we can build on is the capacity to build cumulative models. So to what extent we can build not just predicting treatment response based on depressive symptoms, but what are we getting above and beyond in terms of our neurophysiological and neuroimaging data. And in work that I really didn't have time to present here today, we're also doing this at a population level. So through my role with the WHO, we're currently assessing college student mental health now in 22 countries across 5 continents, and we're essentially screening college students each year. And in now 5 countries, we are starting to integrate online therapies. And what we're hoping to do, given how many subjects we're screening, is that we really want to test the heterogeneity of the treatment effect, or identifying the multivariate characteristics that allow us to predict treatment response in this really vulnerable population. Early returns in these assessments suggest that about 1/3 of our college students are walking around with mental disorders at any given time. But perhaps almost shamefully, only about 15 to 20% of those individuals are actually seeking out treatment, and those rates are actually remarkably lower in ethnic minorities. And so I think as a field, we need to think more creatively about how do we provide different avenues of access to care for this critical population segment. So in closing, I've tried to impress upon you today that I believe personally that the pathway to depression is fairly heterogeneous. I think our lab has taken a fairly diverse approach to try to identify promising phenotypes and biological markers using an array of different tools to better understand vulnerability during this critical life stage. We've tried to leverage what we're learning in the context of depression to identify why certain depressed individuals will go on to make suicidal behaviors. And finally, we're trying to utilize this information really with the hopes of trying to find more savvy ways to predict who's going to respond to different types of treatment, trying to find different ways to actually implement those treatments, and trying to be more effective when we do. So thank you so much for your time, and thank you for all my collaborating funders.
Randy, thanks for that really fascinating presentation. You're covering a lot of ground and describing very impressive work. I'm sure you know that in New York we're a lot less polite than they are in Boston. And so
I've heard.
Let me start out just by being trying to be a little provocative by
Sure.
way of asking some questions. So the issue of like self-injurious behavior characterized as suicidal behavior is a increasingly prevalent or at least noticeable phenomenon, and it's something that is, certainly multi-determined, albeit a more frequent consequence of individuals that have mood disorders than maybe any other, antecedent condition.
Mm-hmm.
And you're saying that you hope to identify, using electrophysiology or MRI, some intermediate phenotypic marker that may be indicative of who is most vulnerable to this, and then applying some therapeutic intervention, CBT or otherwise, to try and ameliorate or prevent it, right? So it's hard, I have some
Reservations.
difficulty about plausibility, much less sort of sensitivity and specificity of the measure of being able to do that in a population, defined by a demographic, and then maybe by a clinical diagnosis, i.e. depression, which in and of themselves are extremely heterogeneous.
Yeah.
So I'd love to believe that you're onto something, but can you sort of provide a little more sort of reassurance or explanation?
Yeah, no, I think it's a great question. I think it's a question that we certainly grapple with. So just to maybe summarize and make sure I'm understanding the question is kind of, how are you taking any of the neurophysiological or phenotypic data that you're identifying and leveraging this into a treatment that could potentially be universally applied? Is that fair assessment?
And know that you're doing something other than placing cold compresses on a hyperthermic febrile individual.
Yeah. So I think that it's such a great question, because I think that we think about this question in a very fractured way in our lab, and fractured intentionally. So one possibility is really just, can we identify who's ultimately at risk? So, by parsing, we're seeing that in our self-report clinical measures, kids coming into acute psychiatric services, kids coming to emergency rooms, upon leaving those services, we have really no idea who's going to hurt themselves. And there's a really nice series of papers that have shown that clinical judgment really is at best chance. And I feel for them, because I don't think that we're better than chance either right now. And so I think part of it is, can we begin to distill a very short, brief way that we'll be able to utilize, necessarily think honing in on a specific disorders across a range of age groups. And those who are most likely to suicide in youth are different from the group that are most likely suicide in geriatric populations, and so on and so forth. And so I think what we're trying to do is really parse the problem into discrete bites. Can we be more effective identifying risk, meaning who is likely to hurt themselves within these acute psychiatric services? The second question that we're trying to answer is, can we identify risk states in real time? So using kind of native technologies, can we build on what we know in terms of suicide theory, psych ache, diathesis stress, sleep disturbance, and start to track that information in real time to begin to use computational modeling approaches to see when there are deviations. Does that facilitate a transition for people who are most likely to go to emergency room, who are most likely to make an attempt, who are most likely to transition from non-ideators to ideators, from ideators to attempters? Because right now, we are really stuck as a field, and we're kind of chasing our tails in the sense that we have not in any way made overtures to improve the short-term prediction of suicidal behaviors. In fact, there's a really nice meta-analysis that came out last year to show that not only we're not improving our ability to predict suicide behaviors, but as a field, we're essentially testing the same mechanism over and over and over again for the last 50 years. And so I think our lab, as well as several of our collaborating labs, have tried to really think outside the box in terms of finding a way both to reach adolescents and find a way to track them and find a way to kind of convert what we already know.
I would like to think that there's some unitary trait or neurobiologic substrate, Ardachian or otherwise, that could be identified that is present in whether it's bipolar, unipolar mood, psychosis, character pathology, that might make individuals more individually vulnerable to it. I just need to. It's hard to believe that it would be simplified into that kind of model, but I'd love to believe that that's the case.
One of the behaviors that we see that doesn't really capture a lot of attention in papers is risk-taking, actually. And it's not sexy. It's not. You don't need neuroimaging to assess it. But we see in our competing models, when we really stack the deck with all kind of very clinical-oriented measures, that escalating risk-taking behaviors, and this is kind of from more of an idiographic perspective. So it's not necessarily the person who's engaging in all of these behaviors, but you just see this uptick in their life, that they're starting to creep in, drink more, smoke more, cut class, things of that nature, that's actually right now in our data in psychiatric populations. We just completed a study of about 1,000 psychiatric inpatient adolescents, that's actually our strongest predictor of who's likely to hurt themselves within 3 months of hospital discharge. And it makes sense. And if you can kind of map that on to existing suicide theory in terms of acquired capability, that maybe the risk-taking is kind of a proxy for this acquired capability of kind of testing out these different means.
Yeah, and there's a history of the D4 receptor genotype, the high or platelet MAO. There's sort of you're on the right track. I just like I say, I'm trying to be sort of a little bit provocative by putting on the spot and saying.
Oh, I'm skeptical too.
Yeah, but at any rate, questions.
Hi, thanks for a great talk. Actually, just piggybacking on that, do you ever look at external factors that may work in combination with risk factors that are part of the individual adolescent, like parents, SES, things like that?
Yeah, so we have looked a little bit at it. We've looked at a lot of things. So we don't get a lot of, I should say in our data, we don't get a lot of predictive value in terms of looking at family constitution or SES. What we do get a lot of value actually is looking at bullying. And perhaps surprising to some, what actually is a bigger predictor of bullying than bullying is bullying others. And what we're seeing is that the teens that are actually bullying others, and more often than not, they've also been bullied themselves, that actually is a pretty strong environmental external factor. Well, I don't know if that falls under external, but I guess in some ways it wasn't immediately obvious to me that bullying others would be such a robust factor that should take notice. And what's interesting is that in Finland they have this really great anti-bullying program called Kiva, and it's been tested now for many years. But one of the group that actually doesn't receive attention in most of these situations is the bulliers. And maybe kind of getting back to something that you alluded at the get-go in terms of the aggression is that when we're thinking about kind of the violence in the United States, these individuals that are coming out and being violent to their other co-students, a lot of times they have been the bullies. And so I think that that's an area that probably warrants a bit more attention.
Yes. Is that Laura? No.
Congratulations on your work. I think you're adding to a really vital you're adding a really vital piece to the existing knowledge in suicidality in adolescents. And I was really pleased to be here and be able to learn so much about it. I've got a couple of questions, if you don't mind. The first is, I was interested in the research you've done around anhedonia, because depression among adults, that work is now revolving around anhedonia. So the fact that it's been replicated among adolescents is great. I wasn't quite sure of your deductions about the attempters of suicide who you said were less likely to pursue effective coping strategies, to pursue reward in random attempts on the money game. So is it that if they had previously won money, they were less likely to pursue the same strategy to pursue money in the future, which I thought was really interesting. With the balloon game?
No, I know. I couldn't quite make out your question.
So the question is, I wasn't sure of your deduction of that. Are you saying that attempters are coping less well with their suicidality, or they're more dysregulated or more severely depressed than ideators?
So no, thank you. It's a good question. What this is saying isn't really about whether they cope or not, or how effectively they cope or not. What we're merely able to show, I don't want to drift too far away from what the data say, is that it's merely showing that among ideators, 70% of the time that they received reward on those uncertain trials, they were likely to pursue the difficult high-value reward in subsequent trial.
Yeah.
But if you see for the suicide attempters, it's 50-50. They're not necessarily utilizing the information to inform future decision-making. They're not exhibiting this win-stay approach, which is kind of what you would expect in more healthy individuals. But what's important to note in this sample is that they actually didn't differ in terms of their mental disorder composition, depression severity, anxiety severity, their suicidal ideation severity, their sociodemographics. They really were remarkably similar. Could it be that there are other differences? Absolutely. But in terms of the things that we assessed, we tried to get as comparable a group as possible.
So what do you make of that?
What I make of it is really that anhedonic suicide attempters are not really able to integrate stimuli within their environment to guide future decision making. So, if you take an interpersonal exchange, they're not walking away from that exchange knowing, did this go well, did this go poorly? And without that kind of very basic knowledge, how do they then kind of navigate the environment around them? Their inability to both detect reward, in terms of their pursuit of reward, as well as to integrate reward, it makes for, I think, a very confusing experience for them.
So are they confused and overwhelmed, or you feel that they're unable to manage their ideation manage the ideation more effectively than non-attempters?
I think ultimately it's how do they manage, it's not just their ideation, but how do they manage their life experience?
Right.
What is a way for them to modulate, negative arousal, or, which direction do they go in? I think that, when you sit down with adolescent suicide attempters, for some of these cases, I just walk away, they just seem confused. They don't really know who to turn to, they don't know how to, they feel stuck. And although I hesitate to use this word, because I don't think that this is what it's representing, is that it makes me feel hopeless in talking to them, but I don't think that the experience that they have is hopeless, because I know even in our own data that hopelessness isn't really what's predicting their suicide. It's something that's more core to the process.
And my final question.
I think we have to move on. I'm not sophisticated enough to evaluate your question, but I love the accent from Australia.
Yeah.
Let me just comment one thing, that there's a study that the NIMH is sponsoring that Andy Crystal is doing, which is testing a kappa opiate antagonist with the outcome measure being anhedonia, and the results came out positively. So it might be something of interest to look into. Can we move on, or do you have something that's burning?
I just want something very quick to ask.
Sure.
You're evaluating CBT for the treatment of major depression. Have you considered evaluating dialectical behaviour therapy, which is specifically targeted to modulating arousal and in interpersonal experiences for adolescents?
Yeah, so we have done studies of DBT in patients with borderline personality disorder. I'm involved in another study where we're actually recruiting based on the context of anhedonia, irrespective of diagnosis. And for that study, we're actually looking and using behavioral activation. And I think that, yes, you're absolutely right. The DBT is getting kind of a core emotion regulation strategies, but behavioral activation is really a therapy that's designed to kind of rejuvenate the behavioral and hedonic system. So,
Myrna?
Myrna.
Thanks. It's very nice after all these months to hear what you're doing. I just wondered what
I'm
you
not
think.
just napping in my office, I promise.
I'm not just arguing with us. I wonder about the old risk factors, like the old studies that showed that family history of suicide attempts or depression was one of the predictors of suicide attempts. I don't think suicides. And the other was an immediate break in some close attachment.
Yeah.
And how do you factor that in? And just one last question. There was a study just published by Christina Hoven in which they showed they were able to prevent suicide attempts. That was in Lancet Psychiatry.
Oh.
And they used I don't recall what the psychotherapy was, but I don't think it was CBT.
And David Brent is coming in a couple weeks, also has a really nice study that's coming out in American Journal of Psychiatry where they're using some kind of innovative ways to reduce suicide risk. But, and those studies, I believe, are not necessarily intervening in real time, but it's just kind of reducing the likelihood that an attempt would occur within a group. But to get to your questions, I'm going to try to tackle them in turn. With regards to these high-risk studies, one of the things that you had said to me years ago that always stood out at me was, if you exclude a lot of the studies in the high-risk, either make this choice. There's this kind of fork in the road where you allow anxious kids into your study or you don't. And as many of you in the audience know, if you allow anxious kids in your study, you're going to increase the likelihood that you'll be able to predict depression in a subgroup. We elected not to actually include anxious kids in our study, which I think may speak in part to why we're getting differences. Ahmad Hariri's group also didn't allow anxious kids into their study. So in terms of kind of patterns of activation, I think that's in part might be playing an effect. The second question you had was regarding family history, right? Of suicide. Yeah, we've taken kind of a catch-all type approach. We've kind of, around the greater Boston area, we had studies going in, emergency rooms, psychiatric inpatient stays, partial hospital programs. And so, we don't necessarily, we're not necessarily able to capture all the variables of interest. And so for a lot of our work, unfortunately, we don't really have the data on which individuals have come from a family. The other problem, is parents are fairly reluctant to talk about it. It was kind of interesting, even in doing the high-risk study, we had to be fairly sensitive about, what we designated the groups, because often parents didn't want to let their children know that they even had a history of depression, even if it occurred not in their lifetime. Maybe they're afraid of kind of shaping the trajectory in some way. But the short of it is, unfortunately, for our data set of about 1,200 psychiatric inpatient adolescents, we just don't have the data on our parents. You had a third question that I'm forgetting, though. But there was another question, too. I'm forgetting. Okay, sorry.
I'm wondering, Jeremy.
Sorry, you can go ahead with
No,
your
no,
question.
no. Go ahead. I was going to put Anne Marie on the spot, but you should
Anne
go
Marie,
first.
you're welcome. So let me first say thank you for a nice presentation and on such a timely and critical topic. I wonder, and I know that you give this thought, there's this tension between studying folks who make attempts and understanding what predicts completion. And some of that you're addressing by following populations long enough to understand whether there are things that you can point to that predict completion. But part of that story also is probably embedded in sex effects, meaning there are many more attempts per completions in females than there are in males. And I wonder if you've looked, I'm sure you have, but if you can say something about sex effects within these data or other data that might begin to give you a sense of what could predict completion, or whether there are other factors that you think highlight completion maybe more than predicting simply whether an attempt happens or not.
Sure. So I'll tell you a peculiarity about our some of our data that is that in our samples we're seeing, as you would suspect, that females are making more attempts, but we're also seeing that younger individuals are actually making more attempts than older. And I don't think that that's actually what's going on at the pop level, but I think it speaks more to how challenging it is now in the context we live in. And so what you're seeing is that in order for you to actually cross the bridge to get even brief 10 to 12 day stays in inpatient programs, you have to be so sick. And so I raise that because, you know, it's always in the back of my head that when we're modeling out our data, to what extent can we actually generalize this information to kind of population level effects? I think mechanistically we can, but I think in terms of telling kind of a psychiatric epidemiology story, I don't think we can, unfortunately.
Anne-Marie?
What's your question, Henry?
I wanted to invite Anne-Marie to comment on this if she has anything to say other than putting it out on social media.
Oh,
Well,
You're very
to
hip.
comment, I think a few of the things I've been texting around the auditorium and talked with. No, I am kind of surprised because one of the things that we've noted with the adolescents and the young adults who are in our program, and mind you, we know these are kids who are high risk. These are kids with anxiety and depression and other diagnoses emerging. An interesting thing is how they develop from early, like adolescence, the ability to shut down and avoid any kind of emotional reactivity. And so, I mean, I'm thinking even of a kid last night who just he's very characteristic of all these failure to launch kids, who sits in his room and either games or watches or reads books, doesn't want any social contact. And when I got him to talk about, you know, what were the sort of setting events, he was able to recall just 3 instances trying to reach out to someone who rejected him, but it wasn't catastrophic. A girl who liked him that he didn't know how to respond to her, and that fell apart. And then the third thing was being called on and not having the answer. And that was like from 5 years ago.
Right.
And, you know, so it's this thing of not being able to experience any kind of normal emotional reaction. And I'm just wondering if you're looking at,
well, so one of the studies that we're hoping, once the lab is up and running, one of the things that we're hoping to get off the ground, and I didn't get into too much of this today, but, you know, I keep saying anhedonia, and in the back of my mind, I'm kind of cringing a little bit because it's not totally clear to me what anhedonia is, in the sense that we know it too is kind of a multifactorial component, and it encompasses things like anticipating, wanting, liking, and learning. And in the study that we're going to try to do, we're actually going to use electrophysiology to parse these different components. And what I suspect, and what our hypothesis was, although our study section didn't agree, was that what we'll see is that different components of the ERPs that are associated with wanting, liking, consuming, learning, that may actually arc the trajectory. So it could be that if you show deficits in consummatory deficits, anticipatory deficits, you might experience certain symptoms. If you experience just anticipatory deficits, maybe you're experiencing anxious symptoms, and so on and so forth. And I think that's a way to start to unpack those processes. I'm kind of answering it from the bottom up for your question, but the way I think of it is that we're giving, the beauty about the German language is that their words are so specific, and I think maybe the weakness of the English language is we have these broad terms that encompass everything. And so, I think that I need to be doing a better job of when I'm saying anhedonia, what do I mean in terms of how it relates to a symptom and syndrome and behavior? And I think that's kind of where I want my lab's work to go, and maybe in that way it could better address some of the clinical experiences that you're seeing.
the only other thing I would say too is like sort of related to what Myrna was saying. I know you sort of indicated that it's hard to get parents to respond or to participate. I really think they're key because there's such an interaction. And even though a kid might be getting rejected or bullied or be a bully, the way the parents are responding, at those times, I think sets with those kids for a long term. So they're key that we have to study
Yeah.
them in some way. And I'm always curious as to what's going on inside the parent's head, with these kinds of evoked potentials, this, that, and the other, in response to their kids' pathologies.
It is interesting, and so Ron Kessler and I and Bill Axon and a couple of others are doing a study based on the initial NCSA epidemiological data. And what's interesting about the NCSA data, for those of you who are not familiar, it includes 10,000 adolescents who are assessed 13 to 17. These were face-to-face interviews. I mean, probably for every paper that anyone writes about adolescents, this is like the first citation that you have various people. But the NCSR sample, the National Comorbidity Survey replication sample, are actually those kids' adults. They're those kids' parents, rather. And so what we're actually doing is we're in the process of contacting, the kids are all between 28 and, the young adults, they're all between 28 and 32 now. And we actually are trying to determine whether the course of one's mental illness is independent of one's parental psychopathology. And so it's not answering all of the questions you're asking, but in the U.S., I think it represents our best hope to know, how independent are one's psychopathology, internalizing, externalizing symptoms, even if you don't want to pigeonhole it to a disorder. How independent is that of parental psychopathology, or is it a dose-dependent effect? The degree to which an individual had all these diagnoses, is it driving kind of the arc and trajectory of certain syndromes and symptoms and disorders that adolescents might have?
What about the ABC study? Is that going to have specific assessments that'll be informative?
It absolutely, the ABCD study? Yeah, I mean, the ABCD study is, I think, going to be kind of an invaluable tool for all of us. And I think, it's not, it's like anything in terms of, it's 1,000 miles long, but only 3 inches deep in some regards. But if it's deep in the areas of your interest, it provides us with a kind of a mass data set that we could really piggyback off of in terms of asking some major questions, especially during the developmental lifespan.
We're going to have to stop because the luncheon is going to commence upstairs, but I just wanted to say, on one hand, there's a need to pursue at a more granular level, whether it's pathophysiologic, psychophysiologic, phenomenologic, the behavior of suicide and the associated conditions. On the other, we have a public health crisis. So what would you recommend doing now before we know everything we need to national average to screen or some other type of measure taken?
Yeah, I'm kind of glad Maddie's not here because I'm sure she has many more insightful thoughts than I, and I'll probably butcher this. But yeah, the short answer is yes. And so consider the following, that only about, at best, 15 to 20% of youth on college campuses are actually seeking out services, but we know that a significantly greater proportion actually need services. And dovetail that with the fact that by mid-semester, every semester across college campuses across the United States, there is a 2 to 3 month waiting list to access services. So I think that we need multiple things to change. We need to be able to figure out different ways to actually provide services. We need to figure out which services are going to be most effective for whom. We also then need to raise awareness. We speak a lot, and we speak a lot during orientation to first-year students, and then as someone migrates to second, third, and fourth year, they're kind of given patches of information on mental health, but I think that this needs to be brought to the fore, and I think colleges around the country need to commit to the fact that they should not have any kid on any waiting list at any time. And you might say, oh, that's a total pipe dream, but I've actually kind of gone around to different countries, different colleges in the U.S., and there are some colleges like MIT who at no time will any person wait if they want services. And yes, they are a private institution with a lot of means, but there are a lot of private institutions with a lot of means across the U.S., and I think that we could be doing a lot better because we're taking a very kind of a reactive role instead of getting out in front of it and saying, what could we do? How could we get inside? How could we use grassroots campaign, particularly with ethnic minority students who are not utilizing these services? How do we reach them? And I think that, it's going to be more than having a billboard that says, Mental Health Awareness Week. It's really going to get into the, where the students live. It's going to be having conversations in classrooms. But I think we status quo is not enough anymore. And particularly because they came out last week with a lawsuit from Boston showing that colleges are now responsible if there's suicides on campus. And so I think colleges are being faced, and they're turning the screws rightfully that we need to do better.
And just what do you speculate as to the reasons why the reluctance or ambivalence?
I think that these are really, really difficult things to talk about. I think that part of it is that it's really, really difficult when somebody needs to activate services if they're help rejecting. I think it's difficult because it's hard to involve parents in this because, as soon as an individual turns 18, they're magically adult enough not to need to be able to interact in that regard. And so I think, it's a confluence of problems. And I don't think that there's going to be a panacea in terms of one approach is going to fix everything. But I think as a starting point, providing even intermediary resources. Now, online treatments are so commonplace in almost every country, and they're still thought of as really secondary or foreign, unwieldy in the U.S. I think that we need to be able to provide people options if they go to a health counseling center and said, okay, there's a 2 to 3 months list. Well, what could they do? Could they do online treatments as a start? Can they be doing teletherapy? So my wife, in full disclosure, works for Google, and as part of the health plan, actually anybody at any time could speak to a teletherapist. The NHS system in the UK now provides, it's totally open access, and they will triage you according to the severity of your symptoms. And if you have the most severe, you kind of jump the line, you see a face-to-face. If not, teletherapy or internet-based therapy. So I think that we need to think and look at how other countries are handling this crisis.
I have a much more mundane speculation about reason. I think it's money.
Money.
It's about investing it. And secondly, educational, it's like mission creep. Educational institutions haven't embraced the need to provide health care to their student body, and it probably has come to the point that it needs to. But it's a great plan on Jonathan's Posner's part, or a coincidence that you're following Laurel Mayer, because she described from her perspective the work she's been doing, and both of you do us proud in working in this very timely area. So thanks, and
Thank you.
look forward to continuing to see how things progress.
Thanks.